The double lumen endotracheal tube allows for ventilation of both bronchial lumens through a single circuit. Its use is indicated in thoracic surgeries requiring lung isolation. It can also be used to prevent contamination from an infected or bleeding lung to a healthy lung. Finally, in patients requiring ventilatory support, the double lumen tube permits differential ventilation of the lungs should it be required for patient care. A bronchoscope will be required to confirm the placement of the tube. A monitor connected to the scope is helpful for improved visualization and for teaching purposes. The equipment required for double lumen tube placement includes a laryngoscope, soft-tipped airway clamps, flexible suction tubing, 2 bronchoscope adapters, a Y-type adapter, endolube, tape, and a 10 milliliter syringe. You will also need a double lumen endotracheal tube that best suits the needs of your patient and a double lumen tube stylet. Double lumen tubes are not measured in the same units as a standard endotracheal tube. Double lumen tubes are measured by French gauge. The 39 French tube can be used for most adults. Both the right and left-sided tubes are designed with 2 lumens. The bronchial lumen is represented by a blue lumen and corresponding balloon and cuff. The tracheal lumen is clear and has a clear balloon and cuff. The bronchial lumen of each tube passes into the left or right main stem bronchus as indicated by the name of the tube. The right upper lobe bronchus takeoff is steep and is close to the origin of the right main stem bronchus. The double lumen tube design specifically accounts for the right upper lobe bronchus angle and location by positioning the endobronchial cuff at an oblique angle to allow for ventilation of the upper lobe of the right lung. Furthermore, it has a fenestrated opening within the bronchial lumen to facilitate ventilation of the right upper lobe. Here you can appreciate the different shape of the 2 bronchial cuffs of the right and left double lumen tube. In addition, the fenestration is present in the right double lumen tube, but absent from the left. Test both cuffs on the endotracheal tube by inflating each with 10 milliliters of air using a syringe. If no leaks or defects are detected, deflate the air completely. Attach the Y adapter to the bronchoscope adapters. The patient should be placed in a supine position with his or her head resting on a foam pillow. Induction of anesthesia is initiated while the patient breathes 100% oxygen. After ensuring the patient can be successfully ventilated using a mask, you may proceed with laryngoscopy. Gently tuck the pillow behind the patient's head to extend the neck. Stand at the head of the bed and scissor open the patient's mouth. Insert the laryngoscope blade into the patient's mouth to the right of midline. Gently sweep the tongue to the left. Advance the blade looking for the epiglottis. When the epiglottis is visualized, lift the blade upward and outward as if you were pulling it toward the ceiling corner. Visualize the glottic opening. Place the endotracheal tube in the right side of the mouth. Advance the tube toward the vocal cords without obscuring your view of the glottic opening. If needed, ask an assistant to apply cricoid pressure to enhance your view of the cords. Watch the bronchial cuff pass through the vocal cords. Carefully withdraw the laryngoscope blade from the patient's mouth. Remove the stylet from the tube. Before further advancement, rotate the endotracheal tube approximately 90 degrees in the same direction as the type of tube. Here, the left-sided tube is rotated to the left. Advance the tube until a small amount of resistance is perceived. If the resistance is considerable, consider placement of a smaller tube. The double lumen tube is typically inserted a distance of 29 centimeters from the central incisors in a 170 centimeter, 5 foot 7 inch patient. For each 10 centimeter change in height, the tube should be inserted or withdrawn 1 centimeter. Inflate the tracheal or clear cuff with a clean syringe. Plug the bronchoscope adapters with attached Y adapter into the tracheal and bronchial lumens of the double lumen tube. Connect the Y adapter to the anesthesia circuit. The patient wears protective eyewear as required for the type of surgery he will undergo. Provide a gentle breath with the reservoir bag, not to exceed 25 centimeters of water pressure. Confirm successful ventilation by watching for chest rise and auscultating the lungs bilaterally. There are several methods to confirm the location of the double lumen tube placement to ensure proper lung isolation. Here we demonstrate the most commonly used and accurate method of confirmation, using a fiber optic bronchoscope. A small diameter bronchoscope is placed through the tracheal lumen and advanced toward the carina. Confirm that the bronchial tube is located within the left main stem bronchus. Examine the carina and origin of the right main stem bronchus. Proceed into the right main stem bronchus to visualize the openings to its lobar branches. Withdraw the scope back to the carina. Inflate the bronchial balloon, watching the tube to ensure that it does not herniate into the trachea. The tube should not change position with balloon inflation. Remove the fiber optic bronchoscope. Reinsert the bronchoscope through the bronchial lumen. Identify the tip of the tube to ensure that it remains in the main stem bronchus and does not extend into one of the left lobar bronchi. If the bronchial lumen is correctly located, remove the bronchoscope. If a right-sided tube were to be used, the fiber optic scope must identify the location of the bronchial lumen in the right main stem bronchus. It must also confirm that the fenestration in the right-sided bronchial lumen aligns with the right upper lobe bronchial orifice. In addition, you can confirm tube placement by auscultation. Clamp the bronchial lumen to occlude airflow to the left lung. Then auscultate the left lung, listening for the absence of breath sounds. Auscultate the right lung to ensure breath sounds are present throughout. After verifying adequate ventilation and assessing tube location with the bronchoscope, you can secure the tube in place. The most common indication for placement of a double lumen tube is lung isolation, as required for the surgical procedure. Thus, it is important to understand how to use a double lumen tube to ventilate only one lung and collapse the opposite lung. To collapse the lung undergoing surgery, open the bronchoscopic adapter of the bronchial lumen. This allows the air in the lung to escape. Without ventilation, this lung will collapse. Next, place the soft-tipped airway clamps on the tubing between the bronchoscopic adapter and Y adapter. This prevents ventilation of the affected lung while maintaining ventilation in the opposite lung. Confirm ventilation in the non-affected lung by auscultating the non-affected lung. Throughout the surgical procedure, continue to monitor the patient for signs of adequate ventilation. Lung manipulation or patient repositioning during or after surgery may cause the tube to change position. A repeat bronchoscopic exam is suggested to confirm tube location.